All right, welcome back, everybody. So we're going to go right into interpreting the EKG. So I'm going to go ahead and pop that up on the screen for you, and let's just get started. We're on page 83 of your workbook. We're going to start off with EKG number 1. Now, the very first thing, let's just zoom in for you here. Remember the 6-step process that we talked about. So there's 6 steps that you're going to use to interpret every EKG. Now, depending on the quality of the EKG tracing, for instance, some things you'll be able to see, some things you won't, but you want to systematically go through every EKG the exact same way. We're going to always start, for instance, looking at the rate, okay? And we're gonna do this, but remember, step number 1 is to look at the rate. Some things you'll be able to figure out just by knowing the rate, right? Okay, so we're going to start with that using, for instance, most of the time we're going to use the 300 method. That's where we go from R wave. We start at 1 R wave. We try to find one that lines up with a solid line, and we count the number of course, big boxes over until we get to the next R wave, okay? So that's using the 300 method. Of course, we could also take a 6-second strip, for instance, and then count the number of complexes in 6 seconds and then multiply times 10. That's 2 ways that I've taught you. Of course, there are more ways that you can figure out the rate, but step number 1 is figure out the rate. Step number 2 is to figure out the rhythm, to assess the rhythm for instance, do you have a P wave? Do you have a QRS? Do you have a T wave? Okay. Is the PR interval like it's supposed to be? Is the QT interval the way it's supposed to be? Okay. The step number 3 is looking for regularity. Is the rhythm regular as we look from left to right, for instance? Is everything regular or is it irregular? Okay. And then if it's irregular, is there a pattern to it? We call that regularly irregular. And if there's no pattern to it, we call that irregularly irregular, like AFib, VFib, any kind of fib, right? Those are irregularly irregular. Step number 4 is we look at axis. So we're trying to figure out, compared to normal, is it a normal axis deviation? Is it left axis deviation? Is it right axis deviation? Or is it extreme right axis deviation? What 2 leads do we look at? For instance, we look at lead 1 and we look at lead AVF. So 1 in AVF, okay? Of course, we can also figure out the mean electrical axis. Step number 5 is we look for hypertrophy. We talked about that earlier in the previous session. We talked about evidence of hypertrophy. So for instance, if we're looking for right atrial hypertrophy, we're going to look for a P wave, for instance, in a V1, and we're going to compare the P wave in V1 and V2 to tell whether it's right atrial or left atrial, for instance. When it comes to ventricular hypertrophy, we're going to look, for instance, in V1, and then let's say V5 or V6, whichever is the tallest or deepest. Remember, for left ventricular hypertrophy, which can cause left axis deviation, we're going to follow that Sokolov line criteria. We're going to look, for instance, at the R wave in V1, and then let's say the S wave in V5 or V6, and then we add those 2 together. And if it adds up combined to greater than 7 big boxes, that would be evidence of left ventricular hypertrophy. For instance, when we look at right ventricular hypertrophy, for instance, we look at V1. We know that V1 should always be negative. However, in right ventricular hypertrophy, you will generally see, for instance, a very tall wave in V1. And then finally, we're going to look for evidence of infarction. So that's where, remember LAD in the T-shirt, where you had on the inside of the shirt, you had the 4. You had V1 through V4 by the left anterior descending artery. And then on the outside of the T-shirt, we had leads 1, AVL, V5, and V6, right? Those were the lateral leads that are supplied by, for instance, the circumflex. And then remember how we cut them in half. And at the bottom down here, we had leads 2, 3, and AVF, okay? And we said those are the inferior leads. So we just went over this in the previous session. So if you didn't see it, make sure you go back and watch that. And for instance, if you're seeing this somewhere else, make sure that you sign up for the EKG Mastery Challenge so that you'll be able to see all of this, okay? So those are the 6 steps. Number 1, rate, then rhythm, regularity, axis hypertrophy, and infarction. We're going to look for this in every single EKG. All right, let's get to work. EKG number 1. I'm on page 83. Very first thing we're going to do is look for the rate, okay? So let's just zoom this in a little bit so we can see a little better. Oh, by the way, this is a good one to point out. For instance, these little, okay, notice this little bar right here, okay? This is a good one to look at because this particular mark, and then the next one, it would be here. So for instance, from here to here represents 3 seconds. Okay, so if I count these little things here at the top, those are 1 second intervals. So we have 1, 2, 3, 4, 5, 6. So this is, of course, a 6 second strip. So to figure out the rate, we can count the number of complexes in 6 seconds, multiply that by 10. So we have 1, 2, 3, 4, 5, 6, 7, 8. So 8 times 10, that rate is going to be approximately, we're going to say approximately 80 beats per minute for the rate. Now, let's use the 300 method. So what we do is we go from left to right and we find one of these complexes that lines up nicely with a solid line. Actually, all of these are about the same, but let's say, so we'll just take, we'll take this one right here. And now what we're going to do is we're going to count over the number of big boxes till we get to the next R wave. So for instance, if we start here at a solid line, this next one, the next big box is 300, then 150, then 100. But remember, we don't say it like that. What do we say? 300, 150, 100, then 75, 60, 50. 300, 150, 100, then 75, 60, 50. Let's just remind you again. We have 300, 150, 100. 300, 150, 100. Then what? 75, 60, 50. And we said we go from 7, 6, 5. And then next we have 4, 3. And then 3, 3, 3. We know that, of course, 4 plus 3 is 7. And then we just have a 3 and a 0. You got it, okay? And all we're doing is 300 divided by 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10. Okay, but 300, 150, 100, then 75, 60, 50. So now let's count it. We're going to start at 1 R wave, and we're going to go 300, 150, 100, then 75, right? So we know that, for instance, according to this 300 method, we're going to get about 75. So one way we get 80, one way we get about 75. There's not much difference between the two. So split the difference. Let's call it 77, okay? So, but here's what we know. Compared to normal, remember a normal heart rate for an adult, for instance, is 60 to 100 beats per minute, okay? If we're talking 75, 77, 80, it's all still within the normal range. What we're really trying to figure out is it normal, is it slow, or is it fast, right? So is it normal? Instead of slow, we're going to call that bradycardic. And then instead of fast, we're going to say tachycardic. So we're really trying to figure out quickly, is it bradycardic, normal, or tachycardic? Okay, so that's the rate. Let's look at the rhythm now. So for instance, we're going to look for, when it comes to the rhythm, we're looking for a P, a QRS, a T, a P wave before every QRS, and the rate needs to be normal. The PR interval needs to be normal within 1 big box. And the QRS needs to be narrow within 3 little boxes. The QT interval needs to be half of the R to R interval. So let's see if we got all that. I see a P, a QRS, a T. I see a P, QRS, a T, P, QRS, T, and so forth, P, QRS, T. Now, so I see all of that checks out. The QRS is narrow within 3 little boxes. So far, so good. Let's look at the PR interval. The PR interval should be within 1 big box. Let's see. Let's go from here. For instance, to here. Is that within 1 big box? Yeah, it is. So 1 big box would actually be from here to here. And this PR interval is within that. So that's still normal. Now let's look at the QT interval. The QT interval is, of course, from the start of the Q to the end of the T. So here, this QT interval is that distance apart. The QT intervals, there's a formula that you can use to calculate it using Bazette's formula. Of course, we have to factor in the heart rate. So as the heart rate speeds up, the QT interval gets shorter. As the heart rate slows down, the QT interval gets longer. But a simple way to do it is we just say that the QT interval needs to be half the distance of the R to R. So if I go from, for instance, let's say we have an R here and an R here. If I take half of that distance, that's going to be about this much space. So the QT interval should be within that. Here, when I look at the QT interval, I would say it's half of the R to R, okay? So the QT interval is normal. Everything about this tells us that this is a normal sinus rhythm. So EKG number 1 is a normal sinus rhythm. All right, let's go to number 2. Oh, wait, I'm sorry. Let's see. We got to do all of our steps. So we did the rate, we did the rhythm. Now regularity, is this regular from left to right? Yes, it is. It's not irregular. Everything is the same distance apart and nothing's changing. We say that's very regular. Now, in terms of axis, I can't really tell axis because I need to compare at least 2 leads. I need at least lead 1 in AVF. You can look at other leads. The way I've taught you to do it is look at lead 1 in AVF. In this case, I only have 1 rhythm strip. I don't have a 12 lead, so I can't really figure out the axis. Now, hypertrophy, I need at least more than 1 lead for that. And for infarction, I can see evidence of infarction in a lead, but I need at least 2 leads that go side by side. So in a group. So for instance, it needs to be like V1, V2, V3, V4, V5, V6, 2, 3 AVF, right? It needs to be groups of leads for us to recognize infarction. Okay. Now let's go to number 2. All right. And as we go along, it's going to start getting faster because it's going to be the same thing over and over and over. Step number 1, we're going to do the rate, right? Of course, we've got a 6-second strip, so we can do the number of beats times 10. So that's going to be 1, 2, 3, 4, 5, 6, 7 times 10. That's going to be about 70. Or using our 300 method, let's see. This one is, none of them are exactly on the line, but starting over from the, we'd go 300, 150, 100, then the next would be 75. So this would be, according to this, it'd be about 70, right about 75. So one method, we get 1, 2, 3, 4, 5, 6, 7. But see, for instance, it's going to be more than 70 simply because there's a piece over here and a piece over here. So that's how we get to about 75. So we're going to say the rate is about 75. Now, when it comes to the rhythm here, well, I've got a P, QRST, P, QRST, and so forth, all the way throughout. Now let's look at the PR interval. I can already tell you that this PR interval is normal. It's all taking place within one big box. The QRS is narrow. It's within 3 little boxes. And of course, the QT interval would be normal. There again, the QT interval needs to be half of the distance between the R to R. It's normal. There again, number 2 is also going to be, it's regular. Step number 3 is regularity. I don't have enough information for axis hypertrophy and infarction here, but EKG number 2 is also a normal sinus rhythm. Okay? Everybody good? Wave at me, guys. We good? All right. Now, let's keep going. Let's go to number 3. All right, let's see here what we got. All right, so, one thing I want to point your attention to here on number 3. We got all that on the screen? Yep. The very first thing that you want to look at when you see any 12 lead is you want to look over here at this little calibration mark. Remember, I was talking about this probably on day 1 or day 2. This is day 6, guys. Can you believe it? But on day 1 or day 2, when I was talking about the EKG paper, one of the things I brought your attention to is this calibration mark. And I said a standard calibration mark is 2 big boxes tall and 1 big box wide. That is standard, as opposed to this would be increase the gain, where you've zoomed in too much to make things big, and this would be too small. So what we want to do is we want to standardize the EKG. So for instance, if you look at this calibration mark and it's not in the standard configuration, all you do is there will be a button on your monitor that reads gain, G-A-I-N, Keep pushing the button or turning the knob, depending on your machine, until it goes back to the standard calibration. Now, sometimes you have to zoom in just to be able to see things, or some things are kind of big and you got to zoom out. But the best thing to know for accuracy is make sure you're using standard calibration, which when I look at this calibration mark, that is the standard. So that tells me that, for instance, the reason this is important, for instance, let's say things are very zoomed in. You may incorrectly assume that this patient has, for instance, hypertrophy. They don't. It's just the gain is zoomed in too much. Okay. Let's see. Okay. So I don't see anything else I wanted to point out there, but let's go into our next steps. So we're going to start with the rate. And oh yeah, here's a rhythm strip at the bottom. When possible, so you're going to have all these 12 leads of the 12 lead, right? But for instance, each one of these 12 leads only gives you 2.5 seconds worth of time. So at least try to look at the rhythm strip. The reason for that is this is going to give you 10 seconds worth of time, which is more information than 2.5 seconds, right? Now, notice that this is 10 seconds worth of time. So if you're using this to figure out the rate, instead of multiplying by 10, we only do that when it's a 6-second strip. This is a 10-second strip. The rhythm strip is 10 seconds, so we multiply it by 6. So for instance, we can count the number of complexes multiplied by 6 in the rhythm strip, and that's going to be 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. 12 times 6 is 72. And we got a little piece over here, so it's going to be greater than 72, but still within the normal range. Now let's do it with the 300 method, which is my favorite. Oh, here's one right here that lines up nicely on the line. All we're going to do is count the number of big boxes till we get to the next one. Let's zoom in for you. Okay, we've got 300, 150, 100, then 75, and it's obviously between 75 and 60. But closer to 75, but less than 75. There again, we actually get about 72, about 74 or so for that one. So we're going to say the rate's about 74. Let's see if I can zoom back out. Okay, now our next step. What's step number 2? We're going to always look at the rhythm. So we're going to check to see, do we have a P, QRS, a T? Is the PR interval normal? Is the QT interval normal? I'm going to go ahead and tell you, just for the interest of time, that it is normal. We check for step number 3 is regularity, right? So we're going to look at this. I like to use this rhythm strip. Now, in this case, the rhythm strip is in lead 2. It can be any of them. All you have to do is hit the button or change the knob for lead, and you can actually change what appears as the rhythm strip. The reason we like to use lead 2 is we think about, for instance, in the heart, the way the normal axis aligns for most people, that actually aligns with lead 2. So that's why we like to use lead 2. So let's go to, we say that when I look from left to right, it's regular. Now, in this one, we have a whole 12 leads, so we can look for axis here. So for instance, what 2 leads are we going to look at to detect axis? We're going to look for look in lead 1 and AVF. So let's do that. Let's find lead 1. Lead 1 is always up here. AVF is always here. Remember I said that the way the most 12 leads, not all 12 leads are in this arrangement. Some of them, for instance, just go down the page like this, but most of them are in this kind of configuration. It depends on the manufacturer and it depends on how the paper prints out. But remember, it's 1, 2, 3. And then remember the story about the dog that was chasing me? And so it's 1, 2, 3 on the count of 3. We're going to run like fast. So that's 1, 2, 3, AVR, AVL, AVF for RLF. Run like fast, or the dog is over there barking and says 1, 2, 3, Ralph. Okay, either way you do it, remember we've covered this. So let's look at lead 1 and let's look at AVF. These are our 2 leads we're going to look at for axis. And what we're looking for is to determine, for instance, in lead 1, is it positive or negative? In lead AVF, is it positive or negative? And we take that information to figure out what quadrant do we get in. Remember this? So we spent a lot of time on that on day 4, for instance. So lead 1, is this positive or negative? Is it pointing up or down? It's pointing up, so we'd say that's positive, okay? Lead 1 is positive. What about AVF? Is that pointing up or down? That's up, so that's positive. If both of them are positive, what's that? That's normal axis deviation. So we have a normal axis deviation here. Now, for hypertrophy, what are we going to look for? We're going to always look at a right lead and a left lead. I like to look at lead V1. Now, should V1 be positive or negative? Remember that V1 should always be very negative, and it is here. In right ventricular hypertrophy, V1 is often going to be positive, okay? The other thing we see is V6, for instance, should always be very positive, and it is, okay? But when we add up, for instance, when we add up this S wave in V1, and then we take the taller of V5 or V6, but for instance, there is no S wave here in V5 or V6. So we don't have any evidence of hypertrophy there. And then there is no evidence of infarction. So number 3 is also a normal sinus rhythm. Okay. Now let's go to number 4. We're going to use our same 6-step process. Let's look at the rate. This one aligns nicely on, see, when you look at a strip like this, sometimes it's a little difficult to know, okay, is this a 6-second strip or how long is the strip? Because there are no marks for us to tell. That's why the 300 method is a good one to use here. This complex nicely aligns with a solid line. So we're just going to count over until we get to the next one. 300, 150, 100, then 75, 60, right at 50. So right at 50. So definitely bradycardic. We know that. Now let's look at the rhythm. We should have a P, a QRS, a T. We should have a P, QRS, T, P, QRS, T, P, QRS, T. Let's look for the PR interval. It should be within one big box. Well, this is one big box, and it's within that. It's right on the line. It's a little borderline, but it's right on the line. So we're going to say that's still okay. And then the QT interval, of course, needs to be half the distance of the R to R. So if I take half of this distance, so that's going to be about here, the QT interval needs to be within that amount of space. Let's see. The QT interval is, we'd say that's about half the distance. So everything there is okay, but the rate is slow. Okay? This is actually going to be sinus bradycardia. Now let's look for, I don't have enough information to look for axis hypertrophy and infarction here, okay? So this is why it's so important that you're doing a 12 lead. Anytime a patient has an abnormal rhythm that's not normal sinus, go ahead and just take that extra 1 minute and go ahead and do a 12 lead. If it's normal, okay, it's normal. The other reason for that, though, is at least there's now one on the record so that if, for instance, patient is now presenting with chest pain at a later date, you'll be able to compare 2 EKGs, for instance, to be able to detect change, especially that comes into place. Let's say you're trying to figure out mean electrical axis. Well, you really need 2 EKGs to compare to see if it's gotten worse or not. Okay. So I'm going to tell you number 4 is sinus Brady. I'm going to go ahead and skip number 5. I want you to figure out that on your own. There's also an answer key at the very end. For those of you who've signed up for the EKG Mastery Challenge, you'll be able to get the workbook, and so it's going to be at the very end. But just in the interest of time, I want to skip over some of them. Now, let's go to here. This is number 8. So let's start with number 1, right? We're going to always start with rate. I like to do the 300 method, so we're going to start with one that's on a solid line. Count the number of boxes over. This is going to be 300, 150. It's not 100, but it's close to 150, but less than 150. So we'd say if this is 100 and this is 150, halfway between that is 125. It's greater than that, so it's going to be greater than 130. So that already tells us that we're in a tachycardic rate. Let's go to step number 2. Now we're on rhythm. Okay, we're looking for the same stuff. When I say rhythm, we're always looking for things for evidence of normal sinus rhythm. P wave QRST, P QRST, P QRST. The rest of it is the same. Now we're going to look for the PR interval. It needs to be within there again, one big box, and it is. Let's look at the QT interval. Well, the QRS needs to be narrow within 3 little boxes. I keep saying it over and over just so because I want you to get it, but make sure you also know this and make sure you're looking for this in every EKG you look for. The QT interval, of course, needs to be half the distance of the R to R interval. That's just a quick way to figure it out, right? Without having to use calipers and all of that. Now, calipers are a great thing to use, but your nerd factor goes way up. Now, obviously, you may not want to carry calipers around in your uniform. Depending on your work environment, having pointy objects in your pocket may not be a good idea. But you could actually take, let's see, I don't have a piece of, well, here's a, I'm just going to grab an index card. So for instance, you could always take an index card or a piece of paper or something, take one complex and put the corner of your piece of paper on one complex. And then, for instance, make a mark at wherever the next complex is. And then just move your paper to see is the distance staying the same. That's one way that you can measure distance is just with the edge of a paper. Okay? A caliper is the best thing to use, but you may not always have it on you. All right, so this rhythm is, so everything is there for, it meets the definition of sinus rhythm, except it's fast. So that one's going to be sinus tachycardia. It is very regular overall. And there again, we can't check for axis hypertrophy and infarction just in one lead by itself, okay? So this one, number 8, is going to be sinus tach. Let's go, number 9 would be a little different. So let's go to number 9. Very first thing we're going to look at is the rate, right? So I like to scan left to right to see if there's one on a line. When I see, this one right here is on a line. So we're going to go 300, 150, 100, then 75, 60. It's kind of halfway between the two. So halfway between 60 and 75. So let's say about 67, somewhere in there. Okay. You could also, because here we do have tick marks to tell us the seconds. So we know this is 1, 2, 3, 4, 5. This is a 6-second strip. We have 1, 2, 3, 4, 5, 6, 7 beats. 7 times 10 is 70. If we do the 6-second strip method, we'd get a rate of about 70. If we do the 300 method, it's about 75, but that's okay either way. Now, the next thing we're looking for is a P wave QRS and T. We have P QRST, P QRST, P QRST, and so forth, right? Now, I'm going to jump ahead for a minute. When I look left to right, this is very regular, but let's go back to the rhythm part. Everything has to be normal for it to be a sinus rhythm. Okay, the rate here falls within the normal range. It was about 75. It's between 60 and 100. That falls within the normal range, but let's pay attention here. How much time should the PR interval be? It should be within 0.20 seconds. That's one big box worth of time. Well, here, notice here is one big box, but this PR interval is this much space. That's greater than one big box, right? So what does that tell us? Everything about it looked like a sinus rhythm, except the PR interval is prolonged. The QRS duration is fine. Now let's look at the QT interval. It needs to be half the distance between the R to R, so that's going to be about this much space. Let's see, from here to here. The QT interval is okay there, but the PR interval is prolonged. So we're going to call this one, this is what's called a sinus rhythm with a first-degree AV block. Now, what are you going to do for this patient? Well, you may not have to do anything because they may be asymptomatic. So you may not have to do anything at all, but you're going to call this a sinus rhythm with a first-degree block, okay? And there again, we can't detect axis hypertrophy and infarction, but we're always going to look for all 6 things when possible, assuming you have enough information to find it all, okay? Just make sure you're looking for it. I want you to do number 10 on your own. And there again, the answer key is at the end for you, but I'm just doing this for the sake of time, but I'm showing you a variety of rhythms. Let's go to, I'm going to skip 11 as well. Let's go to number 12. Okay, let's start with the rate. I like to find one that's on a solid line. Okay, this one is very close to the solid line. We're going to count over. 300, 150, 100, then 75, 60, 50. Whoa. Okay. And then what comes next? 43. And what comes next? 37. So this one is between 37 and 43. So that's right about 40. But notice here, this distance would tell us that it's about 40. However, this distance is quite different than this distance. Oh, wait a minute. So that tells us this is not regular overall. So now we need to look at this a little more closely. Okay. We have a P, a QRS, a T, a P, QRS, T, P, QRS, T, P. And then P. Whoa. So that tells us we have a dropped beat. Uh-oh, we have a dropped beat. What two times do we have a dropped beat when it comes to blocks, for instance? Remember how we have a first degree, second degree, and third degree AV block. Okay, so when it comes to AV blocks, we have a first degree, second degree, third degree. Second degree, of course, has two flavors. There's a type 1, so it's called second degree type 1, also known as Mobitz 1, also known as Winky block, right? Okay, and then we also have a second degree type 2, also known as Mobitz 2, and no other name. Okay, and so it's either first degree, second degree type 1, second degree type 2, or third degree. But what we know is in both of the second degrees, that's where we have a dropped beat. Okay, now remember what I told you earlier about we're going to go to the drop beat. We're going to go to the dropped beat, and then we're going to go to the beat right before it and right after it. And what are we looking for? When I go to the dropped beat, or where the dropped beat would be, where there should be a beat, but there is no beat, we're going to go to the PR interval before it and the PR interval after it. If the PR interval before is longer than the PR after, that's by definition a second degree type 1. Okay? So this one would be an example of a second degree type 1. Okay? So let's go ahead and put that in. This is going to be a second degree AV block type 1. You could also call this a Mobitz 1. You could also call it Winky block. Remember, we had the whole thing of the PR interval gets longer, drop. We say longer, drop. I think I have a Winky block. You got it? Now, I'm gonna skip 13 for a moment, and I'm going to go to 14 because I want to point out some differences. So number 14, we're going to scan this rhythm. Or first thing, let's always start with step number 1, and we're looking for the rate. But immediately I can see that something's crazy here. One thing that jumps out at me is this distance here. That's really slow, okay? But obviously we've got, this one is not on the line, it's kind of halfway between the lines. But I'm just gonna, even if I started with the lines, we have, let's say, if I start here, we obviously have to account for this little section, but we've got 300, 150, 100, then 75, 60, 50. Next we have 43. Either way, we know this rhythm is very slow. It's definitely bradycardic. We can see that right away. Now, I have a P, QRST, a P, and then nothing. Then I have a P, QRST, P, and then nothing. P, QRST, right? So I see some dropped beats. There again, when we have a dropped beat, we're suspicious for a second degree, but we have to figure out, is it type 1 or type 2? What we're going to do is go to where the dropped beat should be, or where there is a dropped beat, where a beat should be. Go to the dropped beat, we're going to go to the we're going to go to the PR interval. Hold on, let me get some water. All right, so where was I? I said we're going to go to where the dropped beat is, and then we're going to go to the PR interval of the beat before and the PR interval of the beat afterwards. And we're going to compare the PR interval. Are these PR intervals getting longer? Like, for instance, is this one longer than this one? Or are they the same? In this case, we see that the PR interval is the same. So this is going to be a second degree AV block type 2 or Mobitz 2. Okay, so this is number 14. It's second degree AV block type 2. Okay. Now, this rhythm is irregular overall, but there's at least a pattern to it. So this is an example of one of those regularly irregular rhythms. Okay. All right, let's go. I'm going to skip 15 because you've seen an example like that, and 16. Actually, you've seen an example like 17 as well. I want you to see if you can figure out number 17, for instance, based on what you've been taught. Okay. And you can always check yourself at the end. Let's go to number 18. Okay, first thing we're going to look for is the rate. Now, this is a little tough, but for instance, we look at, I'm going to tell you that this is a 6-second strip, okay? I want you to look at the number of complexes in 6 seconds. Well, these are not normal complexes, but we can tell that this distance is really far apart. It's a very slow rhythm. So now let's go explore this rhythm a little more. We're always looking for P's, QRS's, and T's, right? And then the PR interval needs to be normal. The QRS duration needs to be normal. And the QT interval needs to be normal. Let's go look. So we have a P. We don't have a Q, but we do have a RS. And real funky looking there. Looks like we have a P, and then we can't really, this is another wide complex and another wide complex. Now here's where I want to point this out for you. We have a P wave here. Here, let's do that in a marker. We have a P wave, a P wave. So notice the distance here. Okay. Then we have a P wave. And then we have a P wave. So notice that this P to P to P to P interval is staying the same. Then we have let's change our color here. We have the QRS, QRS, QRS. This distance is staying the same. Remember, this was a situation where the husband and wife are not talking to each other anymore. And the husband is marching to his own beat. The wife and the kids are doing their own thing. But sometimes they'll end up at the same place together. Sometimes they end up running into each other at the store. This is an example of a third degree AV block. Okay? So this is where we have, for instance, remember how we have the SA node, the AV node, the bundle of His, and then the right and left bundle branches, right? Well, this is the example where we have a complete block here. So no signal is passing from the atria to the ventricles. That's why the atria are up here doing their own thing. That's the P wave doing its own thing. And down here in the ventricles, they're just doing their own thing. That's why the QRS is doing their own thing. So this is an example of a third degree AV block. So in this case, atropine is likely not to work. We need to go straight to pacing for this because the heart rate is so slow that we need to use pads, we need to use electricity. So we're going to do transcutaneous pacing to speed up the heart rate because we need to maintain cardiac output. Okay, because we don't have enough blood being pumped out simply because the stroke volume may be okay, but the heartbeat is slow. So even though enough blood is being pumped out with each stroke, you don't have enough beats. So cardiac output starts to suffer there. So this is a condition for immediate pacing, and then go ahead and prep the patient for pacemaker. Okay, that's number 18. Ooh, let's go to 19. So first step is what? You know this story by now. The first thing we're going to look for is the rate. I like to find a complex that aligns on a solid line. So what we're going to do is this one is actually on a solid line. We're just going to count over 300, 150, 100, then 75, 60, 50. Okay, the rate is 50. Boom, we got it. Now let's check for rhythm. Let's see if all of our stuff is there. P wave. Oh, something crazy is going on with this P wave. What? What's going on? I do have a QRS and a T. This P wave is a little funky again. I got a QRS and a T. Now, the P wave, for instance, should always be upright and rounded, with the exception of, for instance, in V1. In this case, what we notice is we have an inverted P wave. Now, if everything was pointing down, like in V1, that would be normal. But in this case, the P wave is inverted, but everything else is pointing up. So that's not normal. So this is actually what we see in a junctional rhythm. What did we say the rate was? 300, 150, 100, then 75, 60, 50. Boom. So this is a junctional rhythm with a rate of 50. Now, what is the normal rate for a junctional rhythm? Remember, a normal junctional rhythm has a rate of 40 to 60 beats per minute. But then there's this other thing called accelerated junctional that has a rate of 60 to 100 beats per minute. And then there's this thing called junctional tachycardia where it's greater than 100 beats per minute, okay? In this one, this is an example of a junctional rhythm where you have an inverted P wave. The other option is to have just no P wave at all. So it would be an absent P wave and then a QRS and a T. Okay, so it'd just be a flat line. In this case, it's inverted. Either one of those satisfies the definition of a junctional rhythm. Okay. Number 20 is also an example. Oh, number 20 is one of those where it's just the flat line. So there's just no P wave. It's just an absent P wave. Now, notice that here we have this kind of abnormal T wave, though. Okay, this is one of the other variants of a junctional rhythm. Let's check the rate, though. Let's always start at the right spot. So I like to go to one that's close to a solid line. I'm going to use this one, and we're going to count over 300, 150, 100, then 75, 60, 50. There again, it's about 50. There's an absent P wave. The rate's within the normal junctional range. We would call this just a junctional rhythm. Okay, let's look at number 21. Yeah, 21. Okay, first thing we're going to do is figure out the rate. Well, notice that, for instance, this distance is different than this distance, and this one and this one. It's just changing all over the place. Okay, now let's figure out so in this time, since the rhythm, when I scan this from left to right, it doesn't look like everything's the same amount of space apart. So I'm going to immediately say that this is irregular. Okay, so this is regularity. It's irregular. Now, is there any kind of pattern to it? No. This is irregularly irregular. When did I say what rhythms are irregularly irregular? A fib, V fib, any kind of fib. What? A fib, V fib, any kind of fib. You got it. So what we're going to notice here is now we're going to go look for all of our stuff for a normal rhythm. Well, I can't really make out P waves. I do see a narrow complex and then a T, a narrow complex and a T, a narrow complex and a T, but I can't really discern P waves. So I have non-discernible P waves and an irregularly irregular rhythm. This is our classic AFib. Okay. Now, depending on the rate, the overall rate, if it's really fast, for instance, down in the ventricles, if the ventricular rate is fast, we would call that AFib with RVR. So we have AFib with rapid ventricular response or rapid ventricular rate. Well, if this ventricular rate is too fast, we may have to slow that down, of course, with, for instance, a beta blocker, calcium channel blocker. Why would we use a calcium channel blocker? Well, the atria are depolarized by calcium, so we have too much calcium going into the cell. We need to block some of that calcium. We use a calcium channel blocker, okay? Of course, this patient is also, for instance, let's say this is a chronic state of AFib, they're also at risk for clots because the atria, the top chambers, are sitting there quivering instead of contracting. So we will probably need to put them on some type of anticoagulants. The reason is we don't want clots to form because that stagnant blood that's just kind of sitting there, a clot could form. For instance, it could be dislodged, go from the left atrium down into the left ventricle, and then it squeezes out, and now it can go travel somewhere else. So it went from a thrombus to an embolus. So we now have a traveling clot. Okay, let's keep going. I'm gonna skip 22. I wanna go to number 23. All right, this is our classic. What do you think this one is? Okay, let me go ahead and say this is our classic VFib, okay? Now, some people would call this coarse VFib. Some people would call it fine. I'd actually call this a little more coarse. Fine VFib is going to be a little more fine, okay? Either way, they're VFib. What do we do for VFib? We defib the VFib. So one of the first things we're going to do is defibrillation as quickly as we can. We want to defibrillate as fast as possible because their chance of survival just goes way down quickly. So the longer we wait, the less likely we're going to be able to get them out of that and put them back into a normal perfusion rhythm. So we're going to defibrillate them, okay? Of course, defibrillation versus synchronized cardioversion. Defibrillation is where we're just going to charge it, and we need to continue high-quality CPR while it's charging. So we're going to hear beep, and right before we push the shock button, we're going to make sure I'm clear, you're clear, we're all clear. Push the shock button and then go right back to CPR. How long do we take our hands off the chest during CPR? We want to minimize interruptions to no more than 10 seconds. So for instance, let's say this is cardiac, let's say this is the time that somebody's in cardiac arrest, starting at time 0 from the time the first rescuer gets there. There again, we're going to just break CPR up into 2-minute cycles. So every 2 minutes at this time period, this is when we're going to, for instance, switch people because we want to make sure we're switching rescuers every 2 minutes. This is also the time where you'll do a rhythm and pulse check. And all of this, what I have highlighted, all of this takes place in 10 seconds, okay? You want to be pumping on the chest as much as possible. That's their only chance of getting blood to the brain. We're worried about the brain here, okay? It's not about the heart. We're worried about the brain primarily, okay? Of course, what else are we going to do? For instance, all of them are going to get, all people in cardiac arrest get epi. I already talked about why in an earlier session today, actually. Man, we've covered so much today. So everybody is going to get epi, every cardiac arrest. So in cardiac arrest, of course, we have PEA, we have asystole, we have pulseless V-tach, and we have VFib. All cardiac arrest gets epi. Of course, this is going to be our cardiac epi, so that's going to be epi 1 to 10,000, okay? As opposed to epi 1 to 1,000, which is our anaphylactic epi. So we're going to do epi 1 to 10,000. We also need a ventricular antidysrhythmic. So what depolarizes the ventricle? What electrolyte is that going to be? That, of course, is going to be sodium. 99% of the body, of the cells, get depolarized by sodium. There are 2 exceptions, and only 2. Those 2 are the atria in the heart and the thalamus. If I don't say atria, if I don't say thalamus, your answer needs to be sodium. If I say atrium, if I say thalamus, your answer needs to be calcium, okay? In terms of what causes the depolarization or what causes the inside of the cell to become more positive. Let's keep going. Oh, so because it's VFib, that's the ventricle. That's not atria, that's thalamus. Your answer is sodium, so we're going to need a sodium channel blocker. We could use a class 1 Bravo sodium channel blocker like lidocaine. We could also use a class 3 antidysrhythmic like amiodarone. Okay, VFib, we're going to defib. Epi, how often do we give epi? That's going to be every 3 to 5 minutes for as long as you're coding them, okay? Of course, with your lidocaine versus amiodarone doses, you're going to need to follow your protocols for that, okay? I mean, like I know the answer, but it's going to be different for everybody's protocol, so I don't want to save that part. All right, now let's go to number 24. We ready? Okay, this one, we notice that these complexes are very wide. So we got wide complexes. Remember, our complexes should be nice and narrow within 3 little boxes. This is like, for instance, this is one big box here. This is almost 2 big boxes. So that's way big. So we've got wide complex. Now let's look at this ventricular rate here. It's 300, 150. So it's a fast. So it's wide complex and it's fast. So it's tachycardic. The wide complex tells us that it's ventricular and it's tachycardic. Oh, that's called VTach. That's right. So we have, for instance, VTach. Now, we're going to check, for instance, a pulse. Let's check a carotid pulse here. If they have a pulse, it's VTach. If they don't have a pulse, it's pulseless VTach. Pulseless VTach, for instance, is when we're going to do CPR, and we're also going to do, we're going to defibrillate this. So this example is what's called monomorphic VTach, okay? Mono meaning one, morph meaning shape. We notice that all of this has one shape all the way through. That's monomorphic VTach. There again, they need defibrillation, high quality CPR, of course. Now, the only time, for instance, remember we only stop CPR for 10 seconds every 2 minutes if we need to do a rhythm or a pulse check. Now, depending on your monitor, you may have see-through CPR where you can even continue and the monitor takes out some of the interference where you can still read the monitor even while compressions are going. It depends on what equipment you have though, okay? Now, when it comes to ventilations for CPR, of course, I talked about this in an earlier session, but this is just review. When it comes to ventilations to compressions to ventilations, let's say it that way. We're going to always, for an adult, for instance, we're going to do 30 compressions to 2 breaths. We must do 30 compressions and then stop to give 2 breaths as long as the airway is unsecured. So in an unsecured airway, we do 30 to 2. However, once you put a tube in their throat, then chest compressions continues for 2 straight minutes, and then we'll do 1 breath about every 6 seconds, okay? But if they do not have a tube in their throat, you can't breathe and do compressions at the same time because you risk putting, remember those 2 pressures collide, the pressure from the chest, the pressure from the air, they collide, go down the esophagus, and now you're just going to fill up the belly. You're going to cause gastric distension. Now you're going to impede blood flow, and you've likely killed that patient, or they're going to stay dead at that point. All right, let's go to the next one. We're on number 25 because they're already in cardiac arrest. But they're probably going to stay dead at that point. Now, let's go to 25. Notice that, okay, we've got these wide complexes. It's still tachycardic. This is a VTach again. But this one, the shape is kind of changing. And so it's kind of short, and then it gets taller, and then short and tall. This is one variant of torsades. Okay, now, the one that you're probably more used to seeing is this variant of torsades. So both of these, we're going to call this torsades or polymorphic VTach. Okay, now, chances are they're not going to have a pulse. Assuming they are pulseless, they're going to get defibrillation, they're going to get high quality CPR, they're going to get all the rest of the cardiac arrest treatment. But one thing that does change here is they're also going to get magnesium. Okay, follow your protocols, but the purpose of the magnesium is to be able to, for instance, shorten that QT interval so that hopefully you can get them out of this fatal rhythm and get them back into a normal perfusing rhythm, okay? So now, the QT interval is prolonged. It could be medication induced. So for instance, maybe they were on some type of anti-malarial drug, maybe they were on some other lots of medications can cause this. They could have had maybe a digitalis effect, or lots of things could do this. But whatever medication may have caused that prolonged QT interval, that medication may need to be stopped, okay? Let's go to, 27 would be good. Let's go to number 27 here. The one thing, just in the interest of time, I'm going to go ahead and you're still going to follow our same six-step process. What's step number one? We're going to look for the rate. I want you to go back and do this part. Step number two is we're going to check for all the characteristics of a normal rhythm. There again, that we're always looking for a P, QRS, a T. We're going to check the PR interval, the QRS duration, and the QT interval. If all of those things are normal, we'd say it's a sinus rhythm. If it's slow, we'd say sinus Brady. If it's fast, we say sinus tach. But all of those have to be correct for it to be like a normal or a sinus rhythm. Step number three is we're going to check for regularity. Step number four, let's do it over here. Step number 4, 5, 6. Of course, step number 4, we check axis. Step number 5, we check for hypertrophy. And step number 6 is where we're going to check for infarction. Okay. What I want to draw your attention to here, let's see. I want to draw your attention to this part. What we notice here is these peaked T waves. Okay. So these T waves are peaked. I'm going to go ahead just in the interest of time and let you know that this is an example of hyperkalemia, for instance. So hyperkalemia, so elevated potassium. Well, remember our normal potassium. Some books will say 3.5 to 5. Other books will say 3.5 to 5.5. But either way, greater than 5.5 is going to be evidence of hyperkalemia. What we notice in hyperkalemia, for instance, is we're going to have, for instance, often, depending on, now you don't always see this, it depends on the timing. So it depends on when you're catching them and their potassium is elevated. And it also depends on how high the potassium level is. But the longer it goes on and the higher it goes, for instance, you'll start seeing changes in the T wave. You'll also start to see, for instance, the QRS starts to get affected. The P wave even changes. The PR segment, or which makes up the PR interval, it also starts to change. So you're going to see several changes within the EKG the higher the potassium goes, okay? But this is an example, for instance, of hyperkalemia. All right. Now, I do want to focus on, I want to spend a little more time on 28. All right, so let's use our 6-step process. Step number 1 is rate. All right, let's find me a rhythm strip, okay? All right, so we're going to look, here's our 12 lead. Let's go straight to the rhythm strip. I like to use lead 2 if possible. Remember, the rhythm strip is 10 seconds worth of time. We can use our 300 method, or we can just count the number of complexes multiplied by 6 in this case, since it's a 10-second strip. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. So we'd say 13 times 6, that's going to be 78. The rate is normal. We're going to say about 78. Let's call it 80. We're going to say the rate's about 80. But it's not over 100, and it's not less than 60, right? Now, let's look at the rhythm overall. Now, this one's a little harder to see, but here, let's zoom in for me. Let's see here. Okay, so we have a P, QRS, and then we see something's going on here. We've got a P, a QRS, and then this T wave is not exactly right. Okay. What we're going to notice here, let's go ahead and look for, let's go to number 3, step 3, which is to figure out regularity. Well, when I look from left to right, it's pretty regular. It's not like it's speeding up and slowing down. For instance, this distance between the complexes is staying the same. So we're going to say that's regular. Let's go to step 4. We're going to check for axis, right? What 2 leads are we going to look at? We're going to look at lead 1, and we're going to look at AVF. Remember, 1 is always in this position. AVF is always here. So if there again, it's 1, 2, 3, run like fast. Okay, R, L, F for AVR, for AV right, AV left, AV foot. Of course, AV stands for augmented voltage. So we're going to look at lead 1 and AVF. Would you say lead 1, is this positive or negative? Is it pointing up or down? I'd say that's pointing up, so we call that positive. Let's look at AVF. It's a little hard to tell if this is positive or negative, but it looks like it's more down than up. This one's a little harder to tell. Now I want to go, so we're going to skip axis for just a moment. And I want you to go to, what's step number 5? That's going to be hypertrophy. Okay, I'm going to go ahead and tell you just in the interest of time. There's no hypertrophy here, but now let's look for infarction. Whenever I'm trying to figure out, so this patient is probably complaining of chest pain. I personally like to start with leads 2, 3 AVF. I want to recognize that one right away. I'm going to look at clusters of leads together. Remember, we did our lad in the t-shirt. 2, 3 AVF, of course, are going to be our inferior leads. Now let's see. Do I have any ST elevation here? No, I don't have elevation. What I have is ST depression here. I have ST depression in lead 2, ST depression in lead 3, ST depression in AVF. Okay, now if I just were to look at that, you may incorrectly think it's a non-STEMI, but we got to look at all the leads. So I'm just going to start at 2, 3 AVF. Now, for instance, let's look at 1 AVL, V5, and V6. That's another group together. Lead 1, lead 1, I see some compared, okay, so, yeah. So in lead 1, I've got slight elevation. Now, how much elevation do you need to classify it as a STEMI? We generally want to see about 2, some books will say 1 millimeter, but for sure, if we have 2 millimeters, that's 2 tiny little boxes. If we have 2 millimeters of elevation, it's a STEMI. But I see elevation here in lead 1. Now let's look at AVL. So AVL is going to be here. So I have elevation in 1. I have elevation in AVL. Let's check V5. V5, it doesn't really look like it there. And there's no elevation in V6. So right now, for instance, in 1 and AVL, those are the lateral leads. I'm seeing ST elevation in the lateral leads. But I haven't finished looking at all the leads. Let's look at V1. Now, AVR by itself doesn't really tell us much information. Let's look at V1. Well, V1, I don't see elevation there. And what about V2? What do you think here? Do we have elevation there? Okay, what about V3? What about V4? Okay, so here I've got several things going on. I've got elevation in multiple leads. I have elevation in the anterior leads, the lateral leads. This is actually that classic example of the widowmaker where we have, for instance, let's say, remember how we have our heart here? There again, draw these pictures, guys. So remember, we have this right coronary artery coming off the right coronary artery. We have the SA nodal branch. We have the AV nodal branch. And then we have the right coronary turns into the right marginal. And then we've got these diagonal branches here. Off the left side, we've got the left coronary artery that comes down to the left anterior descending. And then it wraps around through the circumflex, right? So, for instance, here, in this case, we probably have a blockage higher up to where we're having some ST segment changes in the leads that are affected by the left anterior descending artery and the circumflex artery. So this is a higher level blockage that's even more serious because a lot more of the heart is suffering here, thus being called the widowmaker, okay? Let's go to... let's do, Okay, number 29, it's another example of a STEMI, for instance, but I want you to figure out which one it is. There again, I've got the answer key already down at the end for you, but immediately we see some elevation that jumps out at us. But I want you to figure out which one this is, and it probably ties in nicely with a story from earlier today, right? Let's go to number... All right, number 30 is a little harder for me to see. There again, okay, number 30 is another good example of, I want you to do number 30 on your own, just for the practice. Go through all 6 steps. There again, we always check for rate, then rhythm, then regularity. We're going to check for axis. We're going to check hypertrophy. And we're going to check for infarction. We're going to do this 6-step process with every single EKG. Now, let me do number 31 with you, though. I'll do 31 and I'll skip. Well, actually, I'll do 31 and 32. So let's do 31. Now, you notice here, I only have 6 leads. So I don't have a full 12 lead here, but this is just for example. What I do want to show you here is we're going to go ahead, let's do our 6-step process. Let's start with rate. I'm trying to find one that's on a line, and I don't see one. Oh, here. If I take this one here, and I try to find one that's on a line, this is almost on the line, so we'd have 300, 150. Wait, hold on. So 300, 150. This is actually probably going to be a little, it's probably right around 100. I can't really see for sure, but I'm going to skip ahead. I'm going to tell you that this one is, everything else is looking normal on it in terms of P, QRST, the PR interval, QRS duration, QT interval. All of that part's looking normal. When I scan from left to right, it's looking like everything's the same distance apart. We're going to call that regular. Now, let's go to step number 4, which is what? What's step number 4? We're going to look for axis. So what 2 leads are we going to look at primarily? We're going to look at lead 1 and AVF. Lead 1, is this pointing up or down? That's up. So is that positive or negative? That's going to be positive deflection. So lead 1 is positive deflection. So for instance, when we draw our, oh here, let's do that differently. Let me change my color here. So remember our circle here, and we have, of course, this one going across is lead 1. This one going up and down is lead AVF. The red part is the positive end. The black part is the negative end. We always start with lead 1, which is the one that goes straight across. For instance, here we know that lead 1 is positive, so this is the positive end. There again, on the positive end of lead 1, the options are either normal axis deviation or left axis deviation. But of course, left axis deviation is not this whole part. It only starts at negative 30 degrees and goes to negative 90 degrees. So this section is what constitutes left axis deviation. Here we know that lead 1 is positive, so we're over on this end. So our options have to be either normal or left. Okay, now let's look at lead AVF. AVF, is this pointing up or down? It's pointing down, so that's negative, so AVF is negative. This is AVF. The red part is positive. The black part is negative here. So we had this combination, a positive lead 1, a negative AVF. That puts us probably in this left axis deviation territory, okay? Now, so we're going to say we believe this has evidence of left axis deviation. Now, to figure out though, we need to know, for instance, is it in this portion or this portion? Because this portion from negative 30 degrees to positive 90, this is actually all considered normal. So how do we do that? We're going to go to the net 0 lead. We're going to look through these and find which one is kind of like neutral. It's not really positive. It's not really negative. It's kind of in between. This we'd say is positive. This we'd say is negative. This is definitely negative. This is negative. This is positive. Let's look at AVR here. It's net zero. So we're going to look at the net zero lead and find its partner. Remember what we do is we have leads 1, 2, 3, AVR, L, F. Run like fast, right? We go crisscross, straight across. Okay? So for instance, this is AVR. AVR is net zero. So we go to the partner of AVR. The partner of AVR is lead 3. So what we do is we go to lead 3, and lead 3, is it positive or negative? Lead 3 here is negative. So remember, let's draw in lead 3. Lead 3 has a positive end going to positive 120 degrees. And then lead 3 has a negative end that goes to negative 60 degrees. Now, in this example, is lead 3 positive or negative? It's negative, so what we do is we go to the negative end of lead 3. The mean electrical axis here is negative 60 degrees. So in this example, we have a left axis deviation with a mean electrical axis of 60 degrees. That is definitely left axis deviation. Remember, left goes from negative 30 to negative 90. This one is negative 60. That's for sure left axis deviation. Okay? What would be causes of left axis deviation? For instance, it could be left ventricular hypertrophy. It could be a left bundle branch block. Many things could cause it, for instance, okay? Now, I'm going to leave these next ones to you. We already went over 34. 35. I want you to see what you come up with on 35, all right? This is a good example. There again, the answers are there at the end.